Okay, well, we'll get started. Thank you all for spending your lunch hour with us. But before we begin, I'd like to take the opportunity to acknowledge that I am joining you today from UBC's Vancouver Point Grey campus, which is located on the traditional, ancestral, and ceded territory of the Musqueam people. And this afternoon, it is with it's a great privilege to introduce Dr. Lillian Hung. Dr. Lillian Hung is the founder and head of Idea Lab, Innovation in Dementia and Aging, and her research examines how technology and environment impact the care experiences of persons with dementia. She has expertise in patient-oriented research and knowledge translation, and she's committed to facilitating connectivity between academia and practice, working collaboratively with interprofessional practitioners to find practical solutions to address pressing problems in care settings. And without further ado, Dr. Hung, the floor is yours.
Thank you. And today I'm also presenting with Cromwell here. Cromwell, would you like to wave your hands? You can see that I'm sharing the slides. You can see that we're co-presenting, and this is a VCH team grant, and Cromwell and I are co-PI. It's one of those team grants that we would have like frontline staff to lead the research project, and Cromwell, it's the nurse who is the frontline staff leading this research. It's really fabulous to see this thing kind of happening in Vancouver Coastal Health. So picture of the team. So it's very interdisciplinary. This happens in UBC, the STEP unit hospital unit. And then you can see that we have like nurses, OT, PT, physicians, frontline staff in all disciplines. So it's really a lot of fun when you get to work with a team to do these, like to improve patient care on your own unit. So this particular technology that we want to try to look at implementation, it's a sensor. I don't know anyone. I'm wearing a sensor ring that helped me to improve my sleep. I don't know anyone of you are starting to use these kind of like technology that help to improve sleep. I know Dr. Wendy Hall is here. She's expert in sleep, and I think people are understanding that sleep's really important for our brain health and for our holistic well-being as well. So especially for the older adults, like sleep is extremely important, and it's difficult when the older person come into the hospital, then in a strange environment and surrounded by all these like conditions that they may not know, right? So it's hard to sleep, and it's not like the cozy bed that you have at home, and the rhythm and the routine that you have at home to sleep. So we wanted to understand how we can better support patients when they are in the hospital, and these are older adults. And we were wondering, what about a piece of technology, a sensor that we can put in the hospital bed to support, to help patients have better data, a better understanding, and also help the clinicians to have a tool to support the patients to help them to have better sleep. So I'll show you a little bit of picture of the device, but essentially this is a device that people don't have to wear, and I think people are a lot these days that wearing wearable, which like the one that I'm wearing. It's a ring, that put on the finger, but like for a older person with cognitive impairment, then it might be. Sometimes it's troublesome to keep track of those kind of wearable, right? And may get uncomfortable and things like that. But this sensor is put in the bed so people don't have to wear it. And it has a whole bunch of features I'm going to show you. And, anyone who work in the hospital that knowing, those call bell that we have in the hospital that drive everyone crazy. Like all you need is just like, you have one person, trigger a call bell, then the whole units get really annoyed and other patients get really annoyed. So this one it's not triggering those kind of alert, and I have the technology that you'll be able to see it on the dashboard. So it's a little smarter. So here it's the piece of sensor, and we work with a company, a local company. It's called TalkTech. TalkTech has this sensor called Sleepsense, and TalkTech has received awards for this particular technology. So it's not completely new. It's been around for a while and has been tested in different settings. So we want to bring it into like our local like VCH here, and we have a small older adult unit, and sleep is especially important for these populations. So we want to see how it works for this population here with their clinicians. And essentially, it's just a small sensor. Then you put it, like the picture here is very clear, that you put it at the, in that the person doesn't have to wear it. It's so the team, they started with like learning about the sensor, how it works, how it put in adapt to the equipment that we have in the hospital. And then the data go to the dashboard, and people can see it. So before we have the sensor, the nurses typically will use like Cromwell will call them the nightingale way. We'll go to each of the patient room, and at night, and we'll put our head to go in and take a peek and then see the person is sleeping or not, and take a guess if the person's not moving. I think maybe he's sleeping. And that's this with the advanced technology. It will give you a lot more data about the sleep of the person. And I'll show you a little bit more, but essentially for this particular project, we want to look at the feasibility and acceptability of having this sensor to have more data about how patients sleep, and we can use it as a tool. Then the patient have a better understanding of their sleep, and the clinician could also use the data so that they could support the patients to find better way to manage the sleep. So for the data collection, what we did, we had a conversation with the person at the bedside. The older person, and these are very conversational. So we try to help the person understand what the research is about. And then there are 3 tools. The first tool is subjective sleep report. I'll show you in a minute that we asked the older person to kind of like, after they had a night's sleep, then they rate the sleep. So kind of like a subjective, like based on the recall, like how did I sleep last night? Yeah. And then we have a staff observation record. It's called Somnolog. This is traditionally what nurses will use in the hospital or long-term care. And they had a chart, and they will like take a peek and see the patient is sleeping or not, and then they record the trending. And then we use this advanced technology, which is the bed sensors. So you can see that these are pictures of the first one here on the left is the questionnaires was a 3 question that we asked the student. We asked the older person to rate the sleep, and we also have I think Cromwell put the questions that we have for the patients, like when we ask the patient to come sit down at the bedside, and we review like what they think subjectively, and what the nurses think about their sleep, and also what the sensors tells about their sleep. Yeah.
I want to insert Lillian, if I may. Back in the previous slide, the rationale being that we introduced the Richards Campbell questionnaire, sleep questionnaire, is basically to quantify the sleep self-report of our patients, because the data from the Sleepsense provides us with a sleep score. So we want to approximate the score that the patient articulates based on the Richards Campbell's tool, which has been validated in so many countries and languages, just to approximate that score, which the metrics provides from the sensor.
Thank you, Cromwell. Yeah. So here, just showing you some of the data of the Sleepsense, and which is kind of very similar to any kind of the sleep sensor that we have in the market. So it tells you, gives you a sleep score, and tell you the different stages of sleep, like how much deep sleep, light sleep, REM sleep the person have, like the awake time, and give you trending and analysis, and so on the right-hand side, this is the nightingale rate of recording the trending, that we will just use pen and pencil, that we'll write down the person that we think that they are sleeping or not. And then a picture here is just the staff, they're recording they're actually watching the dashboard of the data. Yeah, they're coming from the Sleepsense. Yeah.
They're actually comparing the sensor data and the Somnolog data at that particular time.
So, Cromwell, do you want to speak a little bit more about that?
Yes. So on the right side, you'll see we call it the somnolog. It has been a data that our unit has been using to document sleep. It has eventually evolved into a worksheet because we can actually, if you see, there are writings in there, and we write down whether the patient has used the washroom. So it does also address the workload and the type of the work that this particular or support this patient requires of us. So it kind of evolved into that. But the primary purpose of the somnolog we call is to record the sleep of the patient, which is very essential in our geriatric assessment and is one of the essential components of comprehensive geriatric assessment done in our unit.
Right. Thank you, Cromwell. And maybe we can look at this slide. We can talk about this together, Cromwell. So
Yes.
you can see the picture. It's the focus group that we did pre-intervention focus group and post-intervention focus group. So in the pre-intervention focus group, and Cromwell kind of introduce the sensor and kind of tell the team that what the sensor is about and did some training. And you also were able to recruit a total of 27 staff, which is fabulous. Yeah, that having that kind of involvement of the staff on the unit, on the technology that they wanted to implement. And those three questions, the question that Cromwell actually asked, like he facilitated those focus groups and he asked those questions. And in the post-intervention focus group was after we implemented the Sleepsense, and we asked the staff like what were their experience about using the technology on the unit, and there were like a really good turnout of sample size. So 33 staff like participates in these follow-up and post-intervention focus group. And they talk about like what are some of the challenges and the barriers, and like what was that like for them to use such a piece of technology. I'm going to turn it over to you. Cromwell, you give me a signal, then I will move the slides.
Yes, and I think one of the most important key here is that if you work as a nurse clinician researcher, then you get to engage with the staff whom you're conducting the research. So I did emphasize the 12-hour shift there because we cannot really catch the participants in one setting or one shift. So we have to go through that process. That's why there's Zoom interviews or focus group Zoom and hybrid, like in-person Zoom whenever I'm around or my co-investigators are around. So it was really challenging, but at the same time, really rewarding to get their feedbacks over the sensor implementation that we are looking into. We have a very robust, I should say, active participation from our team. It actually expanded to 33 participants in the next phase of our course of our implementation. And it has involved more of the nurses at that time versus care staff who have been really bedside during the pre-intervention focus group. And the leadership from that picture is also present during this conversation. So it was really rewarding.
Yeah, maybe we before we go to the findings, I'm just wondering, like, there's something about you that that you were able to bring like this amount of staff to be so interested, so engaged, and like doing all this work with the intervention, because a lot of times though it's really not easy because it's something new, right? A lot of people say, oh, another thing, it's going to be like more work and it's going to be more trouble. And like how like I know that we have physicians in the team, the pharmacists who say, oh, they ask questions like what's the secret?
I've been there for 10 years and I've not to carry on my chair, but I received a couple of praises from them in terms of patient care. My passion is really to care for the older adults, hospitalized older adults. I think they see it in me, given the bedside care I provide to my patients and the coordination I do during our interprofessional care rounds and the input I share to them. my goal is really to improve our clinical practice, and that is the bottom line. And that is the consistent message that I have been providing our team. And they're all engaged and they're excited about it. In fact, the geriatrician and the psychiatrists are wanting their support too. And that's why we rallied together to make this research really possible in the clinical setting, primarily and most importantly, to help our patients.
Yes, I see the sure goal, right? And the why. So go ahead.
Yeah, yeah. So based on our
Yes.
findings, there are three important themes that were highlighted from our data analysis using CIFR and the description in our study. You have high user acceptance, integration of the Sleepsense technology into the clinical practice, and the implementation barriers and challenges we have encountered during the course of our 3-month clinical trial. Next slide. So in terms of high user acceptance, there generally the perception was the technology is actually user friendly. It was perceived that way because at the outset, I provided the staff with a resource from ToshTech, and they were able to access that online training initially to introduce themselves to the technology use. And eventually, with the eventual training of the staff, which we did with a smaller group and cascaded into a bigger group across shifts, I should say, the 12-hour shifts. So we were able to translate knowledge from that context to the actual technology use. It was an ease on our part because we were using Cerner. And in fact, it made it easier for us because we work on our wows or work on wills. So the data that we get from the sensor were easily accessible through our wows. So it was an easy workflow integration on the part of our nurses and the care staff. So it was a very user-friendly technology, which wherein we look at the sleep data of our patient. So it did address the workflow of our patient. What was interesting, it minimized the sleep disruption of our patients. There's one interesting patient who would not want to be disturbed during the night, and she has this diagnosis of dementia. And whenever we come around and check on him, whenever we crack the door, the patients would shout out and escalate, and we'd call code white. And with the use of this technology, he was actually eventually settled, and it actually facilitated his rehabilitation, and eventually was discharged from our unit, given that context that we are not bothering him anymore. So it has improved his mood and his compliance over his medications over time. So it has improved clinical decision making, definitely on the part of our physicians, as nurse advocates and our care aides facilitating that information to us. We're able to channel a more objective report during our interdisciplinary care rounds. And the doctors are able to address concretely what interventions would be appropriate for the patients given the data that they have, both the somnolog and the technology in particular, confirming also the self-reported sleep of our patients. So at the same time, because of the alerts that this sensor provides, it also addresses workload because we can directly go to the rooms of the patient whom requires our assistance at that particular time, especially at nighttime. So we don't have to run across the hallway and create that noise again, addressing a particular patient's concern, given the alerts it provides. So next slide. Clinical integration. There were thoughts about are we going to pursue with the technology per se or retain our current clinical use of a somnolog, which is documentation? I think from the data that we get, the team really likes to push through with technology. But at the same time, there's like comfortability over the need to check in with the patients physically too. The good thing about this technology is that, as I've said, as it has addressed the workload, we can specifically go through the patient that requires our assistance at that particular moment. So the Somnolog, as I mentioned earlier, is more into a worksheet. So that's why we're kind of looking to how we're going to integrate these two important tools that will address the care needs of our patient. As per our psychiatrist, they said that the more data that they have, the more robust will be their plans over the care of their patients. So one of the comments there of our nurses there is the visual check that the Somnolog requires was still essential, but they appreciated the detailed report of the sensor which it provides us. So it adds up to that layers of need to proficiently or accurately report our sleep observations of the patients. And then, as I mentioned, the workload has been addressed. So real-time assessment provided for by the sensor is really essential given the matrix it provides. It clearly provides or preserves that essential visuals check, which the Somnolog also provides on the other hand. So the integration of the two are really essential. Next slide. Implementation barriers. Over our 3-month trial, there are only actually 1 or 2 glitches of the technology, which is really amazing. And I think it's the Wi-Fi connection at that particular time, because that patient was at the nursing station when we were seeing her on the monitor that she was still on bed. But it was just one time, and we were able to correct it. Now, this sensor operates on a load cell or transducer sensor. So it relies on the weight of the patient. So when you're off bed, it gives you the alert. So we're kind of surprised why the patient was still on the monitor asleep while she was already on the. So there's the positioning of the bed too was a concern over that. So we have to reposition the bed. The alignments of the bed are also essential. So, but then again, as I have said, 1 or 2 glitches during the course of our implementation. Consent was a particular issue amongst our patients, but amongst the 26, among the patients that we have engaged in this project, we only have one patient who did not agree on it. The bigger picture was our project was inclusive. It included all patients diagnosed even with dementia, because we have a substitute decision maker consent, which was developed by the team and the social worker to ensure that the family is also engaged when they agree on engaging the family member to be part of our study. They're also interested to know the sleep matrix of their family member so that they know how to take care of them when they are being discharged from our unit. So obtaining the consent was quite a challenge, but on the other hand, the MRPs or the medical doctors, psychiatrists facilitated that consent acquisition from the patient, because it requires rapport to engage our patients to such kind of technology integration. We thought that there should be a staff user, user that should be in the unit who knows how to admit the patient and discharge the patient, or when there are bed moves, there should be a super user who will able to unplug the system and reboot it again, and some glitches that they can actually address during the course of our intervention. So there are significant comments from doctors and nurses here that this technology is well tolerated, and and um, it is also important for our patients in the future, if we introduce this or use this clinically, to inform them that we are that sleep monitoring is part of our care. So again, there's comfortability on the part of the nurses in terms of its use. As I've said, there's only 1 or 2 glitches during the course of our trial. slide. And I'd like to, and before the conclusion, I'd like to share this story, which is actually a beautiful outcome of our research intervention. This patient is a difficult patient to share with all of these diagnoses that he has. He has this long-standing history of anxiety, and he was just diagnosed with major neurocognitive disorder. And he is so, because of his psychotic thoughts, he's so fixated with him not being able to sleep. But during that course and with the somnologue that we use, it's really hard to defend that because she would negate or avert or defy what we have recorded because he's so fixated or concrete with his sleep experience, which is very subjective. But when we introduced at bedside the sensor and explained to him that he's able to initiate sleep and at the same time maintain sleep, this became a proxy in his mind that he can actually sleep well. In fact, at the later course of his sleep, if you see the August 14 or August 16 down at the end, he's actually sleeping more during the course of that time because CBT was eventually introduced to him. Music therapy was able to introduce to him. So he was accepting treatment from our psychiatrist at that time, given his understanding of sleep. So that's a beautiful outcome, a difficult condition to share, but a beautiful outcome on the part of a technology used given the 3-month course trial with our patient.
That was really a beautiful story because it really demonstrated the technology is not only can be a useful tool for the clinician, but it's also can be empowering too for the patients that they could see their own data about how well they sleep and they could use that to kind of manage, whatever the therapy or the interventions. Yeah, like in this case that you talked about with the CBT. Yeah, that's wonderful. And for the conclusions, that I think we see some promising acceptability and feasibility that really demonstrated from the unit and the geriatric care unit and how the team together implemented and the sensor. They work together and were able to overcome some of the barriers and the learning curve, and the technology. So, when we have more and more these older adults like coming to the hospital, I think that there's really a huge potential to look at how technology can better support to make the hospital environment more age-friendly for the populations. And based on the study that the team has done, I'm very proud. Cromwell was able to publish this paper with his team. You can see in a team that, there are OTPT and and also patient family partners and psychiatrists, and they're all being co-authors for this paper. So this is the first paper that they have already published. If you want to download, there's a QR code that you can download. And I know the second paper has been submitted and it's under review. And Cromwell is working with Peter. Peter's here, another team member working on the policy brief for Vancouver Coastal Health. And I know that there are local health authority starting to adopt the bed sensors. The Dementia Village is using the bed sensors, and Providence, Fraser Health is also working on. They are funded with CanAge to implement the same sensor, the Sleepsense as well. So these are really beautiful outcomes. So thank you. That's the end of our presentations. And I am going to stop share so we can see each other, and maybe Cromwell and I can answer if you have any questions.